Good evening, doctors. My name is Shalan Meena, and on behalf of FDC and MedTalks, in our journey of 52 weeks of Diabetic Essential, I hereby welcome you all to today's live module brought to you by Anazal Zero and in memory of Dr. KK Agrawal sir. Uh, First of all, I would like to wish all the viewers a very, very happy Independence Day, as today we are celebrating 75th Independence Day and marking another milestone in the history of world's largest democracy in India. And in our journey of 52 weeks, we have also come a long way of diabetic treatment. This year 2021 represents a very important milestone in the history of diabetes, as it marks the centenary of one of the most dramatic advances in medicine, the discovery of insulin by a group of Canadian scientists. So before I hand over the platform to Dr. Sanjay Kalra sir for taking us through today's topic, that is long-acting insulin management, let me have the opportunity to announce the names of winners for last quiz. The winners from Delhi are Dr. Ashwini Malhotra, Dr. Umesh Kumar Malhotra, Major Prachi Garg, Dr. Rajan Pradhan, Dr. S.R. Ilwadi, Dr. Sumita Sharma, Dr. Viva Mehta. The winners from different states are from Gujarat, we have Dr. Jitendra Kumar Shah. From Haryana, we have Dr. Mahesh Chabra and Manish Kumar Jain. From Jharkhand, we have Dr. Gautam Datta. From Karnataka, we have Dr. Anupama Swami, Dr. Ramesh Hegde, Dr. Ravi Bhatt. From Punjab, we have Dr. Namrata Puri, Dr. Sanjeev Puri. From Rajasthan, we have Dr. M.R. Chipa, Dr. Vashu Misra. Again, from Tamil Nadu, we have Dr. Prabhakar Ponnu Swami. From Maharashtra, as always, there is a long list. Dr. Vijit Sangvi, Dr. Anand Purandre, Dr. Damodara Jeshwani, Dr. Dharmika Tandon, Dr. Pratap Parkar, Dr. Farid Khimani, Dr. Jayashree Avlekar, Dr. Kaval Saluja, Dr. Kulbhushan Tandon, Dr. Nariman Dr. Neelam Mehta, Dr. Neeta Kochar, Dr. Pratibha Ange, Dr. Praveen Karande, Dr. Rajeshwari Sunku, Dr. Sachin Gujarati, Dr. Sanjay Kanoje, Dr. Sanjeev Desai, Dr. Saroj Narang, Dr. Sopan Tushe, Dr. Vinita Shetty. From Uttar Pradesh, we have Dr. Anil Upadhyay, Dr. Arun Kumar Garg, Dr. Ashwini Kumar, Dr. Ashma Sayyed, Dr. Irfan Ullah, Dr. Pallavi Rai, Dr. Rajesh Jain, Dr. Sanjay Mehrotra, and Dr. Suresh Kushwaha. From West Bengal, we have Dr. Dheeraj Kumar Haldar, Dr. Shantanu Kumar Bhattacharya. That's all. Congratulations to all the winner, and I hand over this session to Dr. Sanjay Kalra sir for take us to today's topic. Over to you, sir. Thank you very much. Jai Hind.
Jai Hind. Thank you, Shilender, and wishing a happy Independence Day to everybody, to all of us. We'll talk today about insulin. And last time, if you remember, we had. I think I have an issue with the sharing today, Shilender. Got it. Okay, now done. So we'll talk today about insulin. Last time we did speak about various types of insulins. And we talked not only of short-acting and premixed, but also of long-acting insulins. We'll continue the discussion today, but we'll focus more on clinical aspects, on issues that we all face in practice. Sometimes we face challenges. I acknowledge the comment by Dr. I.C. Garg sir from Samalkha in Haryana, who says that the recorded versions of this webinar are fine, but in direct transmission, sometimes there's an audio issue. We'll try to fix up the broadband from our side. I also acknowledge a question from Dr. Javed Hassan, who speaks about double diabetes. And Daksa, we'll discuss that later on today. So now, last time, what we spoke about was insulin management. If you remember, we reminded ourselves that there are different regimens, preparations, concentrations, and delivery devices for insulin. The best way to manage diabetes with insulin is to first of all find an indication, to decide which regimen is to be prescribed, then to choose the appropriate insulin preparation, and then the delivery device. That is the order we should follow. If we are not prescribing insulin routinely, it would be a good idea to stick to just one or two regimens, one or two preparations. If we are to start one regimen, that would be premixed. if we are to start in the OPD, if we are to start one insulin preparation, that would be a premixed analog like biphasic aspart or biphasic lispro. These are the easiest to use in the OPD. If we are treating patients in the indoor setting, then we would rather use rapid acting and basal together. That is called basal bolus regimen. But irrespective of what we decide, we must train our patient. We should train ourselves as well. We should help our patient cope with the stress of living with diabetes, help them cope with what we call insulin distress, and help them ensure better adherence. So, when we are prescribing insulin, the written prescription alone doesn't help control glucose. We need what is called VAT, value added therapy. And that's what we'll talk about today. Last time we discussed the natural history of type 2 diabetes. We see that with time, beta cells are bound to fail, beta cell insufficiency will occur, uncontrolled hyperglycemia will set in, both fasting and postprandial, and sooner or later we will need insulin. Why do we need insulin?
So sorry to interrupt you. Your slides are not on slide mode, and
Are you not able to see them?
we are able to see the slides, but it's not on slide mode. The full screen is not there.
Is it okay now?
Yes, sir.
Is it fine now?
No, sir. The slide mode is yet not started, sir.
From my side, it is a slide mode.
Okay, okay.
I
Maybe
think
it
let's keep
got
it like
stuck.
this because I am
Yes,
on
sir.
slide mode from my side. Yeah,
No problem, sir. Okay.
yeah. So when we prescribe insulin, it's not only for short-term control, for controlling glucose and ensuring good quality of life, good health, but at a biochemical level, we are regulating carbohydrate, lipid, and protein metabolism. At a hormonal level, we are preserving beta cell function and also helping the alpha cell come back to normal. And from a long term point of view, we are reducing micro and macrovascular complications. Even though we know all the theory, all of us know the theory, just about one third of all our patients are on insulin. The mean duration of insulin treatment is quite low as compared to other countries, and the dosage is quite low. Now, how do we choose a regimen? We already mentioned last week and today as well that we should be able to choose the right regimen. We classify regimens as being basal, premixed, or basal bolus. But patients classify them as being once a day, twice a day, thrice a day, or four times a day. That is how patients classify insulin regimens. When we want to initiate therapy, we have these four options in front of us: basal or basal bolus, or maybe premixed once daily or premixed twice daily. These are the simple regimens that we can start. And like I said, if you're beginning to use insulin in your practice, stick to just one or two of these regimens. The easiest ones would be premixed. How do we choose insulin therapy? Based upon the glucose profile of the patient. And we already talked about the glycemic pentad, which is a target as well as a tool to achieve this target. And then we talked of the glucophenotype. We should be able to have a phenotype of the patient in front of us. But then these are very biochemistry oriented concepts. So a more humanistic concept would be the glycemic personality, where we assess the severity and style of hyperglycemia, the urgency and utility of glucose control in a particular individual, and we balance that with the risk of hypoglycemia and also the expected adherence and expectation of the person involved. We spoke about the 5A approach, which helps us assess and advise the patient, agree with the patient on a realistic set of goals, and then assist the patient to reach target while arranging follow-up support. These are the regimens that we spoke about. All have their own advantages and disadvantages. But if you want to control fasting glucose alone, then basal would be a good idea. If you want to control postprandial and fasting both, then we would want to use either premixed or intensive therapy. If the HbA1c is high at presentation, which is usually the case in all our patients, then we
Sir,
would have to start
sorry,
premixed or
sorry.
intensive. Yes.
Sir, slides are not moving, sir. We can see only benefits of insulin slide.
Let me stop all over again and then start.
Yeah, right. Sir.
I'll restart the sharing.
Sir.
These are the kind of issues that we face in diabetes practice as well. So it's easy in theory, but in practical, it's quite tough. Okay, is it fine now? Ritu, can you see the slide?
Sir, but not in slide mode, sir.
Yeah, not in slide mode. Yeah. Now in slide mode.
No, sir.
From my side, I'm in slide mode, but at least you can see the slide.
Yes, I can see the slide, sir. But on the first slide, introduction slide.
So let's repeat again. These are the four regimens that we have. We can choose any of them. The choice of regimen is based upon the glycemic pentad, also upon the glucophenotype, and upon the glycemic personality. This is the model that I find most useful for myself.
Sir,
Balance the, yeah.
sorry, but only cover slide is visible.
Now I'm at glycemic personality.
No, can't see, sir.
Now what are
Yes,
you seeing?
now glycemic one.
Personality. So I think maybe the slide show mode is not working.
It's
Now what do you see?
glycemic slide, sir.
Personality.
But not in
But
slideshow mode, sir.
now has it moved?
No, sir.
Then I'll stick to without the
Yes,
glycemic.
yes, moving, now
Yeah.
moving.
Yeah.
Yeah,
So this is
now
the old
glycemic.
fashioned style. Yeah.
Right, sir.
So we can use the glucophenotype, the glycemic pentad, or the glycemic personality. Now I hope you're at personality. You can see the personality slide. Ritu, what is visible to you now?
Glycemic personality, sir.
Fine. Yeah. But and that is the model which I like the best. But whatever you choose, you have to assist your patient. Keep on helping your patient in reaching long-term goals. This is the main difference between acute care and chronic care. In acute care, the doctor is in charge. The patient comes to you. He wants treatment for a pneumonia. She wants treatment for maybe a pain in the knee, and you take the decision. The decision will last for a few days. Patient becomes okay and goes back home. In chronic care, it's more of a relationship of equals. You have to work with the patient. You cannot force the patient to do anything. There are regimens. We spoke of Basal and once daily premixed, twice daily premixed, and basal bolus. Based upon the patient's uh, characteristics, you choose the right regimen. If you want to control only fasting glucose, then basal insulin is fine. If you want to control both fasting and postprandial, you will need premixed or intensive. And if the HbA1c is high at presentation, like happens in virtually every Indian OPD, then we will have to choose premixed or intensive. If the A1C is 9, 10, 11, and maybe there is a significant illness or a concomitant illness along with that, then basal insulin will not bring the glucose down to normal, especially if you have an acute comorbidity, which is not going to resolve without normal glucose values. Then intensive or premixed insulin is required. On the other hand, if there is a high risk of hypoglycemia, then basal insulin would be safer. It also depends upon the patient's mood and lifestyle. How able is the patient to self monitor, to adjust doses? How numerate is the patient? Literate and numerate. Can the patient be in regular touch with you, face to face, or maybe on WhatsApp or phone? Psychosocial factors like family support. All these will help us define what kind of regimen to give. But in limited settings, wherever any of these things is limited, the regimen which is most difficult to prescribe and to use is intensive therapy. So the choice is between basal and premixed. If basal and premix do not work, you can always intensify. You can up titrate to basal plus or maybe basal bolus. Sometimes we give thrice daily premix, though I myself do not use it in practice quite often. Hetero mix regimens are available. We have discussed them earlier. And we have guidelines from various bodies talking about what kind of initiation and intensification strategies are to be used. Last time we highlighted the need to understand insulin technique. That is something we all should be aware of. But now let me move on to newer stuff that we did not discuss yesterday. And let's talk about difficult diabetes. We will follow something that we call the D model. If you're not able to manage diabetes in your patient, whether with tablets or with injections, what is the reason? Let's go through these Ds one by one. And to understand these Ds, let's classify them as biomedical issues, psychosocial issues, and pharmacological issues. So, biomedical, psychosocial, and those related to drugs. Now, the first D is dialogue. It is possible that you are not in tune with your patient. Your patient is not um, able to understand what you're trying to do. So, see if the discussion level is okay. Are we able to have a good trust and comfort level with our patient? If not, let's correct that. Talk to your patient and say, let's start all over again. Let's begin communicating. Let's talk to each other. That is dialogue. Another issue would be D for diagnosis. What is the diagnosis? What is the type of diabetes? Is it type 1? Is it type 2? Is it double diabetes, like Dr. Javed said? It might be pancreatic diabetes, steroid induced diabetes. Maybe we made the wrong diagnosis. So we need to correct our diagnosis as well. If we are sure that our dialogue and our diagnosis is correct, then we look at discipline in daily life. Is the patient following the right diet, exercise? Sometimes patient will say, I'm doing everything that you are saying. But what about pranthas? I eat 3 pranthas a day. I cannot live without that. Or I do everything that you say, but alcohol, that is 250 ml at night. So you look at these things related to D for discipline. Dialogue, diagnosis of diabetes, and discipline. If these are all okay, then you ask for distress. Are you distressed? Are you depressed? Is there drug or substance abuse? Any issues in life that I can help you in? We talk to our patient and we say, if there is any physical stress or any mental stress, counter regulatory hormones will go up and these will prevent your glucose from coming down. So we need to fix these. We can fix these only if we have a dialogue, if I understand what you are going through. Once all these are taken care of, then we still look at other biomedical issues, and that is the disease. Maybe the patient has got another disease along with diabetes. There might be a concomitant disease, we'll talk about these later, which is causing increase in glucose levels. And if all these are ruled out, then again you review your diet, review your choice of drugs, and review the delivery of drugs. You might have written the best medicine, but it's not going to work if the patient is not going to take it at all or is going to take it improperly. So look at insulin technique, look at the injection site, rule out lipohypertrophy. But this 7D approach, classified as psychosocial, biomedical, and pharmacological, helps us handle almost every difficult diabetes. Let me repeat again for all of us. Revise the diagnosis of diabetes, look for concomitant diseases, ensure that dialogue is good, discipline is adequate, and identify diabetes distress and then manage it. And also review your drug choice and the delivery that the patient is following. Now, this was the 7D approach. Let's look at the 7I approach. Indications for intensive or aggressive therapy, usually with insulin. But even if insulin is not indicated, you know that you have to step up the gear. If your patient comes in with infection, inflammation like frozen shoulder, injury like a fracture or a road traffic accident, any kind of ischemia, stroke, myocardial infarction, limb ischemia, our patient is planned for an invasive procedure. There might be an iatrogenic intervention ongoing or coming up, like use of steroids or immunosuppressants. Or patient needs intensive control in the short term because of hyperglycemia, or in the long term because of other complications, then you have to step up your gear and you might need insulin. So first we discussed uh, 7 Ds. Now this is 7 Is. If we understand these, we will understand why insulin is sometimes uh, underutilized in our OPD, and why many times we are not able to give good control of infection or inflammation or post-op or post-injury care to our patients with diabetes. Still, insulin doesn't work all the time. Some patients may be refractory to insulin, and we should be able to understand this. Why is it that our patients are not answering to insulin therapy? If you have a refractory patient or a difficult patient, do a triage and don't hesitate to refer. Don't hesitate to talk earlier about insulin. So, what are the red flags? If your patient had developed diabetes early on in his or her life, patient has had diabetes for many years, 10, 15, 20 years, these are going to be more difficult patients. If your patient presents with microvascular complications, retinopathy, neuropathy, nephropathy, then again, this patient is going to be more difficult. If your patient brings to you prescriptions of other doctors where the therapy is very complex, a lot of permutation combination is going on, insulin has been added to OADs, OADs have been added to insulin, then again, this is a refractory patient. If the BMI is high, patient says my glucose is going up and my weight is going up, that is also a sign of a refractory patient. How will we handle these patients? You simplify the prescription. Start insulin, reduce OADs. Stick to just metformin, maybe SGLT2 inhibitor, but try to reduce the number of therapeutic agents. Try to reduce the number of injections and number of pills. Feel free to use basal bolus insulin in these patients. But if your patient is gaining weight, then don't use too much of insulin. Rather, begin liraglutide. That is a GLP-1 RA. It is expensive. It will cost about 5,000 rupees a month in the lowest dose, but that is the way to go. And tell your patient that our first aim is your well-being. We'll make you happy. We'll make you feel healthy. Your symptoms will improve, and then later on, a week or 10 days later, your glucose levels will begin to come down. So that is the way we have to work. That is the way we have to discuss with our patients. We have a lot of questions regarding this, and I'll take them one by one. But let me just talk about the results of last week's quiz, and then let me share today's quiz with you. There is a question: do we get prizes for the quiz? And the answer is yes, you do. And so many of our doctors win prizes every week. Maharashtra and New Delhi usually lead from the front, but all across India we have people logging in. And they very correctly answered last week's question. Insulin deficiency is associated with increased ketone production. And an isotonic solution is one that has an osmolality similar to that of plasma. Our questions for this week are: the first one is, which statement is correct? A, insulin suppresses the activity of glycogen synthase. Remember that insulin is an anabolic hormone. It will promote anabolism. B, insulin mediates glucose uptake in the brain. C, prediabetes is a condition characterized by increased risk for future development of type 2 diabetes. Yesterday, the Endocrine Society of India celebrated the International Pre-Diabetes Day. It was 14th of August, 90 days before World Diabetes Day. D, the rise in insulin concentration after meal ingestion is reduced in type 1 but not in type 2 diabetes. So let me repeat all these questions. Only one of them is correct. A, insulin suppresses glycogen synthase activity. B, insulin mediates brain uptake of glucose. C, prediabetes is a risk factor for type 2 diabetes. And D, after meal ingestion, insulin concentration rises in type 2 but not in type 1. Our second question, very simple one, and this is our, it's our NRZL 0 question. The concentration of electrolytes is similar in the intracellular fluid and the extracellular fluid. Is this true or is it false? Two simple questions for all of us. We've had a great evening today. I apologize for all the glitches, but let me take all these questions one by one. We have a question from Dr. Manu Sharma. Hi, Manu, how are you? How do we adjust the morning and evening dose of premix? So, the first thing to do is to do a fasting, that is pre breakfast, and a pre dinner. So, we stabilize these first. If the fasting glucose is high, keep on increasing the dinner dose of premix by 2 units or maybe by 10%. And your fasting will soon come down to around 100, 120. That should suffice. 100 to 130 should be fine for most patients. At the same time, you keep on doing an evening glucose before dinner at 8 or 9 p.m. But do counsel your patient that that glucose should be tested at least 3 hours after the evening snack. This evening glucose will tell us how much of dose we have to give in the morning. Some patients will just not be able to achieve a good evening glucose with premixed. For such patients, you can always add an afternoon dose. It might be short-acting metformin. It can be metformin plus voglibose or metformin plus acarbose. It can be metformin plus a short-acting secretagogue like repaglinide or glipizide. Glipizide will be a very economical option. Metformin plus glipizide, and these will help bring down the evening glucose level. Once we have fixed up the pre-breakfast and the pre-dinner, then after that we begin checking the postprandial glucose and we see if we need to increase insulin or not. Usually things are fine. Sometimes they don't work. Then you have to adjust the diet. So let us say throughout the day my glucose levels are normal on biphasic aspart, but post lunch or let's say post dinner, post breakfast, there is a huge jump, maybe 220, 240. Then I'll ask my patient to reduce carbohydrates and increase proteins at breakfast time. Increase cottage cheese, that is paneer, or boiled chana, or roasted chana, and reduce the chapati or idli or dosa. Another question from Dr. Bhanumati Sharma is, how do I prevent weight gain in a patient who is on insulin? This is actually a major challenge. So Dr. Bhanumati, various options. Keep the insulin dose low. Use less of rapid acting insulin and more of basal insulin. Secondly, add metformin as much as the patient can tolerate. You can add an SGLT2 inhibitor. You can also add liraglutide. All these will help prevent weight gain. They will reduce the dose requirement for insulin. This is pharmacological modulation. Along with that, lifestyle modulation. Ask the patient to take less calories, take less carbohydrate. Don't go hungry, compensate with proteins. Secondly, increase exercise level, regular exercise as much as the patient can do. So these are some very important issues that we have. There are other questions. Dr. Sumaya Khan asks, if glucose is above 500, what do we do? Do we give insulin or insulin IV? If your patient is stable, hemodynamically stable, metabolically stable, there is no evidence of respiratory distress, no clinical evidence of acidosis. That means pulse, BP, respiratory rate all are normal. Then we don't need to give an insulin drip. We can give subcutaneous insulin. In my OPD, I ask my patient to stay with me for an hour or so. We don't even admit the patient. We just say sit with us. For that 1 hour, the patient will sit and talk to the diabetes educator, to the receptionist, to the physician assistant, and they will learn lots of things about diabetes care. We talk to them. We would like to give you 4 injections of insulin a day. Will you be able to manage? Patients sometimes say yes, sometimes they say 3 or 2. Whatever they have said, we give either a premixed insulin or we give rapid acting insulin, something like 10, 12 units, and we ask the patient to wait for an hour. And we check the glucose again after 1 hour. Many times I actually use Enerzal Zero in such patients in summer. So we say you take this drink, and what I tell them, it is as if we have admitted you. We are giving you the same electrolytes, but actually we are not going to charge for the admission. You just sit with us. Patient's confidence goes up sitting that 1 hour in the OPD. And then after 1 hour, you look at the glucose. There'll be usually a fall of 80 or 100 milligram percent. In the meantime, you've taught diet and exercise, other things. Maybe you did a complete hemogram, a urea, you got those tests, and then you send the patient home and call back early. If, however, patient is hemodynamically or metabolically compromised, patient has got high respiratory rate, high pulse rate, thready pulse, low blood pressure, ketonuria, moderate or large, signs of acidosis, then it would be a good idea to admit the patient. If you're admitting in the ward, even then subcutaneous insulin will be fine. And if you're admitting in the ICU, then insulin drip is better. So I hope Dr. Sumaya that helps. And Dr. Umesh Malhotra, Dr. साहब आप हैं हमारे साथ तो हम भी आपके साथ हैं. It is Independence Day, but we are all together. And what better service can we do? Uh, what better homage can we pay to our fathers of the nation, to our forefathers, than actually trying to help all Indians? And that is what we are trying to do today. Vibha Mehta ji has an issue for her prize. So Vibha Mehta ji, I will escalate this to the FDC team and I'm sure you will get it. Slides, Sanjay Mehrotra ji, are available. I apologize for this glitch today. I don't know why it occurred, but they are available online, and we can share the slide deck with you separately as well. So, and Dr. Gangadhar has a point. Patient is highly reluctant to initiate insulin. That's true. How to motivate? So, multiple issues are required. You try to find a motivational cue for the patient. Some people are motivated by subjective things, by emotional things. So you might say, Madam, please take insulin so that we can get good glucose control, so that your arthritis will become better, your joints will become healthy, so that you can knit a sweater for your grandson. All this has to be said in one sentence, no comma, no full stop. Now, the picture that you have created is the grandson knitting a sweater for the grandson. Now, chances of the lady taking insulin are more. You are trying to achieve better health. Try not to scare the patient. This tone, take insulin, otherwise your kidneys will spoil, you will die. This is not welcome. I use it in the OPD sometimes, but even I get upset when I use it. I actually should not be doing that at all. So try to find positive things. This is called positive imagery. For some people, it may be self-centered positive imagery. So, sir, take insulin. This will help improve your heart health. You will not have breathlessness. You will be able to exercise more. You will become healthier. This is a self-centered positive motivation. Other people are altruistic. They want to benefit others. So then the answer will be, or the statement will be, sir, take insulin so that you are able to live on your own. You will not be dependent. You will not have to trouble your son and your daughter-in-law if you are ill. You will be able to help your family. So here again, positive motivation for the family health. So these are different ways of motivating the patient. And over the coming 5 to 6 months, we will keep on talking about motivation for therapy. To Dr. Sudhir Jain and Dr. Ashish, I really don't know what happened to the slides today, but we will try to fix that up next time. Clarity, Dr. Prachi was actually quite poor today. And Dr. Hitesh, thank you for cheering me up. Dr. Javed had the most difficult question, and that was how to diagnose and how to treat double diabetes. So, what is double diabetes? It is a type of diabetes where there are symptoms and signs suggestive of type 1 and suggestive of type 2 diabetes, both. There are different types of double diabetes and type 1.5 diabetes. Let me describe them one by one. First is there is a form called LADA, LADA. This is also called type 1.5 diabetes. Patient presents to you. Initially, you think the patient is type 2 diabetes, but then as you keep on following up the patient, sugars are not controlled, and then you realize it is type 1 diabetes. These patients will have positive antibodies, but they are expensive tests, no need to do in routine practice. From a North Indian perspective, the LADA patients will be handsome men, beautiful women, light colored eyes, very beautiful eyes, light colored hair, brown or gray, light black hair, very fair complexion, stigmata of autoimmune disease, like a malar rash, a goiter, arthritis, or maybe history of arthralgia, maybe vitiligo. In these patients, the treatment is insulin. Another type of 1.5 diabetes is the patient comes to you with a very explosive onset of disease. Patient comes in with very high glucose, ketonuria, maybe ketoacidosis. You have to treat with insulin. But within a couple of weeks, you find that the glucose levels are coming down very fast. And many times you stop insulin and you are able to manage with metformin alone. This is also known as flatbush diabetes. These people will be typical Indian phenotype, metabolic syndrome phenotype, normal Indian complexion, dark hair, more hirsute body in both men and women, less hair on the scalp, more of androgenic alopecia, and stigmata of metabolic syndrome. In these, the treatment is short-term insulin followed by metformin and maybe SGLT2 inhibitor or GLP-1R. The double diabetes word that is used is being seen more and more often now. This is children with type 1 diabetes who take a lot of insulin, who eat a lot, they overeat and they over insulinize themselves, and then they come in with weight gain and all the associated side effects of weight gain they will come in with acanthosis nigricans, skin tags, darkening of complexion, central obesity. For these people with double diabetes, we will add an insulin sensitizer. Metformin is the drug of choice, and we will try to reduce the insulin dose. We have to do a very careful dietary recall in such patients to see if they are eating too much of oil or ghee and maybe too much of carbohydrate. So we need more discipline for these people with double diabetes. And remember the 7D concept that we showed you: dialogue, discipline, distress, then diagnosis of diabetes, diagnosis of disease, concomitant disease, and also a review of drug therapy choice and drug delivery. If we are able to focus on all these, we should be able to manage diabetes in virtually every difficult patient as well. So we've had a great day today. We have more questions. Dr. Junaid has a tough question. Um, how risky is it to introduce PIO in an older patient more than 65 years? Patient does not have CCF or volume overload, and patient has a normal DEXA. So, Dr. Junaid, I use PIO in such patients, and I will be very confident in saying that I use it. I fully agree with you. Patients want to try full OADs. If you feel there is insulin resistance, no harm in adding pioglitazone. What I tell my patients is, if you feel there is swelling in the feet, come back to us immediately. If you feel you are gaining weight and you feel you have to go to the tailor to get your suits or your trousers altered, please do not do that. Come back to us. We will change your medication. We will alter your medication instead of you having to go and buy new clothes. So we just say this to our patient. Patients smile, they laugh, and they do come back. And you can use pioglitazone 15 milligram very safely, even above the age of 65. If your patient has unstable heart disease, unstable heart failure, has been admitted repeatedly in hospital for heart failure, then maybe not a good idea to use. But it is a very commonly used drug in my clinic, Dr. Junaid. And thank you for raising this point. So we've had a great day today. I'd like to thank all of you as well for joining in on Sunday. I apologize once again for the technical glitch. Thank you and Jai Hind.
Sir, once again, a wonderful session, sir. Like you said, in theory it looks easy, but in practical it is difficult. The management of diabetes. But sir, your practical examples and the way you explain the theory and give the practical tips, I'm sure all the audience have got the good grip of the subject and the topic today, sir. And insulin is one of the toughest topic and toughest therapy to understand. So thanks a lot for your time and your dedication that on Sunday and Independence Day you have come and joined us, sir. Thanks a lot for that. And I would like to thanks all the audience also for joining us. And I'm sorry once again for the technical problems, but I'll make sure that the slides reaches to all the audience who have joined today. Thanks a lot. Have a good day.